Right. Hello and welcome to the BDAU workshop on clinical datasets session 2. Today I'll be speaking about HES, hospital episode statistics. Yesterday we kicked off by talking about CPRD, primary care statistics. We mentioned a bit about HES yesterday, but today I'll be going further and giving much greater detail about what HES is, what it's used for, how it can be used, etc. Okay, so HES is hospital episode statistics, essentially to do with secondary care, and secondary care in the UK comprises emergency and urgent care, ambulance trusts, NHS trusts, mental health trusts and care trusts. Again, this is a bit of a follow-on for those of you who were here yesterday, because yesterday I did mention the role of the GP within the NHS and how the GP is a gatekeeper to the rest of the NHS for patients. The GP refers patients on to secondary care. So it would make sense that access to secondary care is generally through referral by a primary care clinician, self-referral, or emergency admission. Emergency admission, obviously that's ambulances, blue lighting and racing through the streets. Self-referral is when somebody decides on their own to head to A&D because of symptoms they may have been experiencing for a while and ignoring until they get nagged by a family member or close friend into getting some help. And obviously referred by a primary care clinician, that would be normally the GP or some other primary care person. Now, HES is an administrative database containing details of all admissions, outpatient appointments, and A&D attendances at NHS hospitals in England. Very important, HES is England only, whereas CPRD, the primary care data set, is England, Wales, Scotland, and Northern Ireland. So that needs to be borne in mind. HES is collected during a patient's time in hospital and it's submitted to the Department of Health to allow hospitals to be paid for the care they deliver. Those of you keeping up with the headlines in the news would be aware of the funding crisis and various overspends. That's all calculated through HES submissions. It's collected monthly and it's got high-level data by region, hospital, condition, etc. HES is designed for research. So for those of you here who are researchers, which is almost all of you, it's suited for your purposes. Some of you might want to take down the website address at the bottom of this slide so that you can have a look at it and get a lot more detail about HES yourself. You'll have endless hours of insight and delving into that much more than I can provide during this brief talk. Right. Who is HES for and what are its uses? HES provides data for healthcare analysis. Now that's for your national bodies and regulators, so the likes of Monitor, the Care Quality Commission, the Department of Health, etc. For your CCGs, formerly your PCTs, so your local commissioning organizations, they would have some, make use of HES. Provide organizations that's basically your trusts or mental health trusts or ambulance trusts, essentially your secondary care providers, researchers, that's your good selves, commercial healthcare bodies, that would be pharmaceutical companies or healthcare, private sector healthcare research companies, of which there are many. And not a lot of people are aware that patients and service users and carers can derive quite a lot of insights from some of the reports which use HES. It's used to monitor ongoing trends and patterns in hospital activity. So to look at one hospital or a particular trust over time, say over a number of months or over a number of years, or a particular season, so winter over the past 20 years, etc. That could be analyzed through HES, which is how we can draw the conclusion that the hospital winter crisis is worsening or becoming better or staying the same in terms of XYZ criteria. It's also used to assess the effectiveness of delivery of care, can be used to support local service planning, provides the basis for national indicators of clinical quality. As I mentioned earlier, it reveals health trends over time. So within HES, you've got just the raw numbers of, for example, the A&D attendances over a number of years could, when adjusted for changes in population of the catchment area of a given trust, could allow you to determine whether the burden on that trust is increasing or staying the same or reducing. So that could be one use. So if you look at the use of a particular unit or the incidence of particular diagnosis within HES, again, that gives you your trends over time, or the incidence of particular of the carrying out of particular procedures within HES. Again, that's another trend that you could look at to determine various outcomes. It's also used to inform patients' choice, to determine fair access to healthcare. Slightly controversial one, this in terms of what we all know about the ongoing friction between the Secretary of State for Health and the junior doctors. HES is used to develop, monitor, and evaluate government policy. Some of you here are junior doctors, so the list said about that, the better. I'll just move on quickly. It's also used to support NHS and parliamentary accountability. So as you can see, HES does have a wide range of uses, but the key here is, for most of you, is that it provides data for researchers, and the various uses to which it can be put. Most of you would be interested in things like the trends and patterns, and the indicators of quality, the assessment of effectiveness of delivery of care. Now, the categories of HES data files are inpatients, outpatients, A&B, and critical care. I'll show you some HES files later, but inpatients is the most detailed. In the current version of HES, the most recent release of HES, there's over 300 variables in HES inpatients. However, not each variable is populated for every episode. Some of those are only used for certain purposes, or when there's certain incidents. For example, if there's about a dozen columns for birth weights, those are only relevant where the admission has been for delivery of babies, and you only use the multiple columns where there's multiple births. So a lot of the columns are just placeholders, essentially. Outpatients, again, similarly, there's lots of fields, most of a decent proportion of which are not used for each episode. Accidents and emergency, again, the same applies. Critical care, that's information about patients in the intensive therapy unit, in the ICU. So you don't have the wide variety of fields, because there's only very few signs and symptoms being monitored in critical care that need to be reported on for the hospital to get paid for that activity. Okay. Very often when people speak of HES data, what people really mean is HES inpatient data. So that's the most commonly used HES data file. It includes up to 20 fields for diagnosis. These are ICD codes. The first diagnosis field shows the primary diagnosis for that episode. The other diagnosis fields are secondary diagnosis, so things like your complications or side effects or other diagnoses that were made during the course of that episode of hospitalization. And there's up to 24 fields for procedures carried out. The first procedure field contains the main procedure carried out. again, similar to diagnosis, the other fields are secondary procedures, and a single operation may contain more than one procedure. So, for example, a transplant, you'd have separate procedures, but it's a single operation. So the OPCS codes, that would be plural OPCS codes, but it's a single operation. The data dictionary for HES inpatients is available via the HSCIC website, and you may download it when you can. That's freely available. Now, outpatients data. An outpatient appointment is different from an inpatient appointment in that the primary diagnosis is already known, so it would normally be either follow after a period of admission, for further checkup or monitoring, or you might have been on a course of treatment supervised by a primary care clinician, and there might be a need for some outpatient appointments at a hospital. So again, the diagnosis would already be, the main diagnosis would already be certain. So the same as before, up to 20 diagnosis fields and up to 24 procedure fields. Now, for those assessing outcomes such as factors such as costs and impact of various types of hospitalization or various conditions that cause long stays in hospital, socioeconomic data would be important. HES does include IMD scores. HES A&D contains details about episodes in accidents and emergency units. So again, the data dictionaries are available online, freely available online for whoever wishes to download them. And the same applies to HES critical care, which holds information on patients held in intensive care units. Any questions at this point?
So I have a question, Dalton. Yesterday when you talked about CPRD, you had mentioned that it's coded with ring codes. That's how you would search for conditions.
Yeah.
With HES, it's coded at ICD-10. So I'm just curious why there's a discrepancy, and if at any point we're going to have ICD-10 in primary care as well as secondary care, in terms of from the data.
Right. The reason for the discrepancy is, I believe, historical. Read codes were introduced in medical practice, I believe, in the 80s, and they were in use in primary care. However, when HES started, the decision was taken from the start to use ICD-10. And what was the second part of your question?
And so will there be a point where from the data in the future, you would have both CPRD and HES coded to ICD-10? So if you wanted to use a code list to define diabetes, you could just use one code list for both the CPRD and the HES data?
The honest answer is I don't know, but I could find out and get back to you.
Thank you.
Okay.
I'll just say something real quick as well. Part of what we're doing within the BDAU is loading these data tables into our own database. So we should be able to do correlation between the codes. So that'll be part of the
So you're doing the
platform.
mapping of the-
That's part of the
the
platform that we
codes
would
of
build
ICD-10.
as well, yeah.
Okay.
So that should make it easier if you need to search for a single condition like diabetes.
Okay, thank you.
Right, and now the process of obtaining data from HES data from HSCIC is a long, painful process. Sometimes it's those of you who have applied for HES data or been involved in these processes know that it's a massive headache, a very lengthy process. It involves these stages where you go through application approval and then you get to access your data for the required length of time. At any point while the data is held, you could be subject to audits by the HSCIC to ensure security of the data and that it's being used for the purposes stated, and that your institution isn't holding too many copies of the data, more copies of the data than stated in the application, and that access to the data is being strictly controlled. Okay, so with the application, there's a lot more to it than this. But the key things you need to be sure of while applying for HES data is that you've indicated the legal basis under which the data will be accessed. You've described in great detail the security of the data handling and storage systems which would be used when you do receive the HES data. The application is checked by HSCIC for basic feasibility, so whether they can fulfill the request. So in some cases, what the researcher is requesting might be something that HSCIC is beyond the remit of the HSCIC. If that's the case, the response to your application would be quite prompt, but they would refer you on to whatever other body or organization could provide the data you're requesting. And you need to be clear about the purpose for which you're requesting the data. Again, you may want to copy that web page address and have a look at the description of the process for those of you who will be either intending to apply for access to HES data or who are currently in the process, in the back and forth of going through the application and access process for HES data. Quite an ordeal sometimes. So it's best to do it well, get it right first time to minimize the duration of the process. Okay, I'll just quickly run through the approval process. So once the application, once you've fulfilled all the requirements in the application process, then it goes through to approvals where it's assessed by the information assets owner at the HSCIC prior to submission to the Data Access Advisory Group. And then, but within that, any necessary action is discussed between the information assets owner and yourself as the researcher and completed. So again, that could take a significant period of time. It's presented for a final pre-advisory group review. It's formally presented to the DAAG, to the advisory group by the information assets owner, and then an outcome is reached. It could be recommendation with caveats, deferral, withdrawal, or rejection. If it's a recommendation, then data sharing agreement is drawn up for your applicants, for your signature, and it moves on to the happy stage of you actually getting your hands on the data. If it's a rejection, then you discuss what happens with your information assets owner. Otherwise, if it's a recommendation with caveats, or go through the data sets, produce what matches your request. The request you detailed in your application form. So the years, the fields you wanted, the level of detail you had requested, and then it's made accessible either by secure file transfer or you being given access to their system to interrogate it. We at Imperial use the secure electronic file transfer, and audit and deletion, which I mentioned earlier. Audit is simply to ensure that the organization handling the HES data is fulfilling their obligations within the data sharing contract and data sharing agreement. So, like I said, it's in terms of security of the data, confidentiality, controlling access to the data, just your general data handling. And each HES data sharing agreement has an end date by which all the data must be deleted if the data sharing agreement is not renewed for a further year or two, or period of 6 months or whatever. So at the end of the period of usage, the data must be deleted and must be shown to HSCIC to have been deleted. So, and that's done by sending a certificate of destruction to the HSCIC. Right. So just briefly about the data sharing agreements and data sharing framework contracts. The data sharing framework contract, it's essentially your legal obligations in terms of handling HES data and your organization's commitments. So a few key things to bear in mind are that people handling the HES data must be trained and made aware of their responsibilities. And well, for most of you researchers, that's it's obvious things like maintaining confidentiality, not discussing the data beyond work or with people not involved in the project. Just basic things like those. The HSCIC does retain copyright of the data unless otherwise agreed. This needs to be cited in any publications. Any information tools derived from the data must not be provided to other organizations unless the HSCIC gives consent. These are not just formalities. HSCIC does check that these obligations are being adhered to, and when they are violated, permission to use it can sometimes nullify the data sharing framework contract. So these have to be adhered to. Importantly, the data must be accessed, processed, and used within the European Economic Area only. For those of you who use file sharing applications to do work between your office at home or while on the move, HES data being uploaded to things like Dropbox or other file sharing services is a massive no-no. It must only be used simply because Dropbox servers process the data in their data centers, mostly in the US. So there's a whole lot of guidelines around accessing, processing, and using HES data. Again, use of the data must comply with a whole plethora of applicable legislation, and which is why people handling HES data need to be made aware of their responsibilities. So there's a massive list of legislation relevant to HES. Not to scare you off using HES data, but you do need to adhere to a whole list of legislation. Essentially, just be sensible and maintain privacy and confidentiality around data, and don't share your username and password with others. Maintain basic things like your discretion and basic privacy and confidentiality around the use of the data. If you're sensible, you shouldn't fall foul of any of these. Right. The HES data files themselves are downloaded through the secure electronic file transfer tool. This is really only relevant for those who will be accessing the HES data directly. But for those using the HES data, the files are text files, which are contained within compressed folders. So that means you may then import them into your data analysis package of choice, whether Stata, SAS, SPSS, whatever. Load them into any database. And now, here we go. We, as researchers, you need to think carefully about identifying the data required for your research. Ideally, you should have a well-defined research question. You prepare when you go into your institution or company's data manager for data extracts from HES. Ideally, you'd have a list of relevant diagnosis and or procedures that you're interested in. Ideally, what you should be giving your organization's data manager is a code list, but a list of conditions is okay, as that can easily be translated across. So you then need to think of the variables that you're interested in. So you would sit down with your organization's data manager and think of the subset of variables that would be relevant to your work. And you think of the range of years that your study would cover. And that should help in identifying your study cohort and extracting the relevant data. So I've essentially gone through this already. So your data controller would put together an algorithm for your data extraction that's then codified as syntax that's then executed. You are then given your access to your data and subset. I mostly use SPSS here to carry out data extraction requests. This is for for an ongoing project in the Center for Health Policy. So this is just some code to extract some data on admissions for which the primary diagnosis was type 1 diabetes, type 2 diabetes, or complications to do with diabetes. So each of those are the codes, and what we were looking for was any of the diagnosis fields from diagnosis 1 to 20 having any of those codes you see there. So it's just asking the program to go through the entire data set for the given period and just extract the cases for which those criteria applied, and then to save the resulting file with that file name. Again, not something most researchers need to worry themselves with. Your data controllers will deal with this stage of the process for you. And I mentioned that you need to be aware of, or at least in describing your process to your data manager, you would narrow down the list of variables required. This is an example of syntax, just reducing down the number of variables required for a given data extract. So it's just instructing the program to save these variables. I think these are about 76 variables out of the 309 from that inpatient's file. So I had gone through the uses and capabilities of HES data earlier, and in terms of a key example of monitoring and evaluating policy, you might want to look at the work done by Professor Paul Elling and Alex Bottle, who are based here at Imperial. They've done a lot of work over the past, I think, 10, 15 years using HES for looking at things like the weekend effect on admissions and outcomes within hospital. So I did describe this, go through this in fair detail earlier. Now the main limitation of HES is that it's an administrative, not a clinical data set. So it gives fine-grained detail about what happened, when it happened, what procedures were carried out, what the diagnosis were, things like for a delivery, the birth weight of the baby, the state of health of the babies delivered, etc. But it doesn't give things like dosage, strength, formulation, etc. of medications administered. So it's limited in that sense. And right, any questions at this point? Yeah.
Dalton, in terms of follow-up, what's the maximum length of follow-up you would have available for patients in HES today, in terms of years? Is it 10 years, 15 years, 20 years?
Well, here at Imperial, we've got HES inpatients back to 2003-04. HES started, the data in HES dates from 1995, so that's maximum of, I think, about 20-21 years follow-up. And but yeah, the data we currently have, our current data set is back to 2003 for inpatients.
In terms of, you just mentioned Professor Paul Elling did a lot of work on outcomes.
Mm-hmm.
How does the HES evaluate our outcomes? And the other question is just on, in terms of thinking in code, if I was to bring some sort of code, how do you define outcomes? And is there any way of identifying people who've been readmitted once discharged? Is that supported by HES as well?
Yes. Within, I'll take your last question first. And Joshua, did you want to chip in? Right. Within HES, it's got episode keys as one of the variables.
Okay.
So the episode key identifies the episode. However, within a given year, there may be several episodes pertaining to a specific patient.
Right.
So each patient has their encrypted identifier. So there's an encrypted HES ID for each patient, and so your follow-up, your outcomes would be looking at each patient within their multiple episodes, looking at the diagnosis. So if there's a specific diagnosis within the first episode, and then another diagnosis within the second episode pertaining to that patient, and then you can deduce that it was a side effect or complication from the initial procedure. Now about the work of Paul Elling and Alex Bottle, they mostly looked at, well, one of the things they looked at was the weekend effect, in terms of do more people die, or is there greater mobility at weekends in hospital? They used various statistical methods, including cumulative summing, QSUM charts, again, I would advise you to look at their papers. There's a wide range of papers they had published in high impact journals, and Alex is quite accommodating. If you want details about the methodology he used, he'd be happy to answer emails
Okay.
on that.
Thanks.
And any
Just a question. So, with regards to the outcomes, obviously an outcome you measure is mortality. What you're saying, morbidity-wise, how do you classify that? You said you also measure morbidity as an outcome.
Yeah, you could.
How do they classify in terms like?
Just by looking at, for example, the diagnosis codes,
Right.
looking at a particular patient, either within a particular year or through a number of years, if you look at the sequence of diagnoses that occurred, and within each spell, you can determine things like the duration of the episode. So you'd be able to look at reoccurrence of specific diagnosis or a particular complication. So if a particular diagnosis is known to be a sequelae or a complication of a particular condition, you can trace that through HES.
Okay, so for example, if a patient had a prostate operation, then they go home, they have a bleed, they come back, then you can trace, you can deduct that this was a complication. If they have something that won't require an admission, that may be missed, is that right? Like for example, incontinence or something like that, because they may not require admission, hence they won't come under HES, but under the CPRD. And the death, is it just, does it have to be a hospital death in order to record it? Or how do you know that somebody died?
Again,
And when they died, if they weren't admitted? And
for deaths, those are recorded in the ONS, Office of National Statistics. So you can link HES to ONS to determine things like 30-day mortality, 90-day, 1-year mortality. So that's how the various monitoring bodies determine,
so the mortality you'd pick up essentially would be inpatient mortality from the HES.
Indeed.
Otherwise, you'd look at what Joshua said about the linking databases. Is that right? To be
Yeah.
able to derive.
Yeah.
Okay.
And I think with ONS,
Yeah.
you have to request it when you request the data from HES. They do the linking.
Oh, they do the linking.
Yeah.
Yeah. So you can request HES ONS linked data.
The same with CPRD as well. You can request it at the time when you
And you
request the
said,
data.
Joshua, that it's feasible to look at, because they, as we discussed earlier, they code differently the diseases like ICD-10
Yeah,
version
it's
during the process.
it's
so-
all possible, but
Yeah.
a lot of it has to be done when you request the data, because the data linking, when they give us the data, for instance with HES, they give us an encrypted ID that's not linkable to other data sources.